A 49-year-old female patient presented with headaches. I am showing you an axial non-contrast brain CT. Describe the findings.
Okay, looking at the images. The axial non-contrast CT scan demonstrates a large midline suprasellar mass extending superiorly into the third ventricle. The mass exhibits a mixed solid and cystic appearance with prominent central and peripheral calcifications. There is significant dilatation of the temporal and anterior horns of the lateral ventricles, consistent with obstructive hydrocephalus at the level of the third ventricle. The fourth ventricle retains a normal size and configuration. The combination of suprasellar location, cystic elements, and calcification in an adult is highly characteristic of a craniopharyngioma.
I am showing you pre- and post-contrast T1 sagittal MRI scans of a different patient, along with T1 post-contrast and T2 MRI scans of the current patient. What do they demonstrate and what is the differential?
The comparison T1-weighted MR images demonstrate a large, predominantly solid pituitary macroadenoma with uniform enhancement and suprasellar extension. This macroadenoma exhibits a snowman configuration due to narrowing at the diaphragm sellae, with no cystic or calcified components. The MRI of the current patient confirms a large suprasellar lesion with intrasellar extension, showing mixed solid cystic elements and enhancement of both the solid parts and the cyst wall. The differential diagnosis for a suprasellar and intrasellar mass includes pituitary macroadenoma, craniopharyngioma, Rathke's cleft cyst, meningioma, metastasis, chordoma, and internal carotid artery aneurysm.
Explain the demographics, origin, and pathology of craniopharyngiomas.
Craniopharyngiomas account for approximately 4% of all primary intracranial neoplasms. They exhibit a bimodal age distribution. The first peak occurs in children aged 10 to 14, and the second peak in adults in their 5th and 6th decades. These are benign ectodermal tumors that arise from remnants of Rathke's pouch along the pituitary stalk. Two main histological subtypes exist: the adamantinomatous type, which is common in children, and characterized by cystic fluid containing cholesterol crystals, and the papillary type, which is more common in adults and predominantly solid.
How do you radiologically differentiate craniopharyngioma from pituitary macroadenoma and Rathke's cleft cyst?
In that case, pituitary macroadenomas are predominantly solid, show uniform avid enhancement, show no calcification, and cause symmetric sellar enlargement. Craniopharyngiomas are mixed solid cystic, contain calcification in up to 90% of childhood cases, and show rim or nodular enhancement. Rathke's cleft cysts are smaller, simple cysts with a regular ovoid shape, demonstrate no calcification, and show no or minimal thin wall enhancement. Lateral extension beyond the internal carotid arteries into the cavernous sinus is common in adenomas but extremely rare in Rathke's cleft cysts.
What complications should you look for, and how would you manage this patient as a radiologist?
Well, key complications to evaluate include mass effect causing obstructive hydrocephalus, compression of the optic chiasm, and pituitary stalk compression leading to hypopituitarism. As a radiologist, I would recommend a dedicated brain and pituitary MRI with gadolinium and thin sagittal cuts to map the relationship to the optic chiasm and hypothalamus. I would also recommend checking visual fields and endocrine function to address hypopituitarism. Finally, I would recommend referral to neurosurgery for surgical resection, which is often combined with postoperative radiotherapy for residual tumor.